Okay, good. Thank you. So it gives me great pleasure on behalf of the Jindal School of Government and Public Policy at the OP Jindal Global University in Sonipat, Haryana, to welcome Professor Bhramar Mukherjee for a special distinguished talk in the program of our first annual conference on economics and public policy. The School of Government and Public Policy, Professor Mukherjee started in 2012. It so happens that it's the first university degree offering a master's in public policy in the country. We've had universities offer degrees in public administration, and the way they've understood public administration is really about the institutions and mechanisms for executing or implementing policy. And if you look at the curricula for those old public administration schools, they haven't focused on the design and formulation of policies, and also the disciplinary range in those curricula is limited. But we started the program in a very interdisciplinary way, knowing that public policy requires good judgment, drawing insights from multiple social sciences, and that therefore our students should have a foundation, or at least be able to learn how to draw insights from multiple social science disciplines, even though they may not be specializing in economics or political science or statistics for that matter. But we emphasize a good deal in the program on statistics. We have 2 courses for the MA program in the public policy school, and of course in the MA and the BA economics there's statistics, but that you'd expect. But unlike others in the public policy, many others have started offering masters in public policy after we did in 2012. Now there are about 25 other institutions in the country that call the masters public policy, but they don't give that much emphasis to statistics as we do, and that's really because there's so much to be learned from data. And this is, while human beings are, may regard their freedom as inherently something that should not be predicted, that their actions should be unpredictable, otherwise they would be like robots and determined. And so free will requires I don't know if the free will exists. Nonetheless, there's a belief that some parts of our behavior is not predictable, but a great part of our behavior as human beings is predictable, and therefore big data and statistics can capture the predictability all around us, and you are greatly specialized in that process of discovery from data what is actually going on. And you're well known in the country, not only because you're whenever some Indian acquires a distinction, our newspapers publicize that, and your distinction is the first woman to be the head of the Department of Biostatistics at Michigan. That's was given a lot of publicity, but more than that, more importantly, your work has been important, and it gives us some satisfaction that if you do work of such high quality as you do, policy makers will sit up and take notice. So I think you may have had something to do with India's quick and early action in a lockdown at the very early stages. Subsequently, we may have let the guard down, and other things have happened. But nonetheless, it's reassuring to know that an epidemiologist and your warning didn't go unnoticed in the beginning. I also hope your warning, your finding that many more have died in India as a result of COVID-19, and the infection rate is vastly higher than official statistics. That's very timely. It's important. That's a form of speaking truth to power. But I also have to teach our students to tell the truth about power. And if you study power, some obfuscation of the truth and the data, for narrow political ends is only to be expected. But we also need people like you to uncover and say what's likely to be the reality despite claims of government. So we are very, very honored and delighted to have you in this conference, and we look forward to you hearing your remarks. It's wonderful that you could be with us despite the significant time difference between us and you, and it's rather early start where you are. So welcome, and over to you.
Thank you so much, Dr. Sudarshan, and everybody else for joining this talk. This time difference always exists, but in India, you often give talks in the evening and sacrifice your family time. So this is totally fine. And I'm really honored to be a part of this conference. And in July, I was in India and I was driving from Delhi to Himachal Pradesh, and I saw your institute, the fascinating building. And I asked my friends that all of these brand new institutes are coming up. I sometimes wish that I could find a job. And so I just want to mention that we drove past, and the buildings and the facilities are truly impressive. We drove past Ashoka, Jindal, and so a new landscape of education has emerged in India, and it's extremely exciting to see young blood and modern thinking engaging in terms of public policy, in terms of data. My entire career has been to really talking about data and thinking about data policies. So, and I think that I got fascinated by data very early on in my life through my education at the Indian Statistical Institute. But one complaint, an inherent complaint that I always had about teaching statistics in India is that it's very theoretical. You get to learn all of these methods, but never really learn how to adapt them to a real context and jump into a real problem and solve and show some, navigate some solutions with data and help evaluate policy. So hopefully you will get to see a glimpse of that through my lecture today. And as it was mentioned that we started working on the COVID-19 data in India, the limited data that exists. And so one of my part of the talk that you will see will emerge that we need more data. We'll have lots and lots of good models and statistical methods, but at this point, we really need to revolutionize and overhaul the public health data systems in India. So I could, if it was next week, I could probably give this talk in person. I'm supposed to embark on a flight to India in 2 days. So this is very timely. And so, so how can statistics help influence and evaluate policy? So that's going to be sort of the tale of these 2 years for me. I would like to start with the quote by one female statistician that I admire a lot. So Janet Norwood, she was one of the pioneers in labor statistics, and she worked with the federal government for years and years with the goal and with the mission to change the federal data systems in the United States. She was the first woman president of the American Statistical Association, and quite a remarkable individual. And so this was in 1994, many, many years ago, but some of the principles of what she says, that we really need good data for policy purposes and policy evaluation. And the data have to be of high quality, they have to be timely, and they have to use state-of-the-art techniques. Statistics cannot stand still, and statistical agencies cannot stand still. So I feel like, if I think about the statistical agencies in India, and federal data system, they are standing still and for many years, and it needs the information systems, and the IT revolution has really swept the whole world. And I think we need to move forward with time. And the pandemic has really underscored these gaps. And that's something that I really want to talk about. It sort of has become my mission. Even if nobody listens, it's my responsibility to actually showcase the problems with data. So I think that we truly have been borrowing on the future because we have not undertaken the kind of actions and the kind of research that needs to be done to change the system. So to give you a context, because many of you may not know what Dr. Sudarshan mentioned about when we started this work before India's first national lockdown to set up the backdrop, and then talk about some of the death underreporting work that my team has been doing and many others for the last few months. And then the final piece is something that I'm really excited about. It's not a retrospective analysis or reflection, but really quantifying the effect of policies. For example, wearing masks, social distancing, reducing capacity, what really works? We roll out many things and everything has a cost to human life. But what is really, really effective in India or in a particular context? How do you, we have seen 2 years of natural experiments all around the world. How do you tease apart the effect of an intervention? So I think more work needs to be done in order to really think about a nuanced dial-up, dial-down method for intervention now that we have vaccines, now that we have new variants, and the entire landscape has changed from where we were in March of 2020 with the national lockdown. So this is but before I begin, I really have to thank my team. So in the early days of the pandemic, when all of us were feeling quite lost, unsure about when we are going to be able to see our families and friends in India again, and it was the stay-at-home order at Michigan on March 16th, we started getting together to think about proposing a model for India. And that was our sustenance, that was our inspiration, that was our way of staying connected with each other. And this work definitely has had more meaning than just the papers or just the communication or just the product. So it takes an army of data warriors to, if I always dreamt of a data revolution, so this is my army. I just want to thank each and every member of this team and many others who have joined all over the world to help support our cause. Together, we formed this team called COVID-19 Study Group, and we built an app. And I'm going to show you the features of that app, because I think that despite the papers and everything, I think the app remains the most important contribution. So when we started, you probably cannot believe the y-axis of this figure, that the number of cases were very few. There were a total of 536 detected cases and 11 deaths due to SARS-CoV-2 in India. And we were sitting sort of in March, and these are the last 3 days on the figure when our team was working tirelessly to come up with a model for India. So we were concerned. India has by this time, we all know that India has a young population, so that is to its advantage. But on the other hand, it also has a fragile healthcare system. The insurance framework is not robust, and there are people with COVID-related morbidities which have high prevalence in India. So obviously, it was not clear which way India is going to go, whether it's going to have the benefit of the young population or it is going to, the healthcare system is going to crumble. So, but it is a hugely large population. Social distancing is very hard. Enforcing policies that will affect daily wage earners is extremely challenging. So we wanted to work on India, and that was very clear. So this was a Medium article, and as an academic, of course, this last 2 years have been a very eye-opening lesson in terms of public engagement and communication. We are used to writing peer-reviewed articles and which appears and sees the light of the day 2 years after we have thought about it. Typically in statistics, it takes about 2 years to publish a top tier public journal publication. So by the time it actually people read it, you have already lost interest. And so here was a time when you needed immediate communication. So this was our first article, which was circulated very widely, and as Dr. Sudarshan mentioned, made quite an impact because there were no formal predictions and quantitative models for India at the time. And so here we compared India with US and Italy standing on March 19, 2020, and showed that the trajectory, this is exponential growth. And this was a very simple model, and that would lead to a growth, and exponential growth cannot be underestimated. And so the model that we used is, I'm not going to talk about models today. I'm going to not rely on equations, but more on images and figures to show you the current data. The model was a compartmental model, and I was very intrigued by this class of models because, as you know, in statistics, we always start with y equal to x beta or a regression type model. As opposed to this was compartmental models determining the dynamics of a contagious process from one compartment to another, depending on its transmission rates and removal rates and other parameters that you have to learn. And so this class of nonlinear systems of models was very intriguing to me as a statistician, and I was trying to learn it from my colleagues in my own department who are using these models and developing software and tools to actually analyze the data from Wuhan in China. And so this is one good thing about taking an off-the-shelf tool and having a team to be able to implement it nimbly so that you can actually communicate with the public. And this model is essentially a latent Markov process model where you are modeling the state of the different compartments, the susceptible, infected, and recovered compartment at time t, and relating that to time t+1, depending on certain transmission parameter. This is the stochastic system that's emitting the virus incidence curve or the infection curve, just to say in a more broader term. So using this model, we were actually evaluating policies and intervention because none of us knew that what is going to happen and what is the effect of, say, travel ban, what is the effect of social distancing, what will happen if you engage with cautiousness after the lockdown, what will happen if you actually engage just as you were without any precautions. So we were trying to create counterfactual virus incidence curve. That's what you see on this slide in different colors, that what happens if you lift the lockdown in May, what happens if you lift it in June, and so on. And so using this model, but all of those values of the interventions were conjectural because we did not have 2 years worth of data. And this is important because I'm going to revisit this in the last part of the talk, showing how to actually estimate these interventions given what actually happened in India, and how can you tease apart that, finesse your model because now you have more data. So there are lots and lots of things you can do on the computer when you have a system, when you believe in a system, and the system usually has its own limitation of how the process of the virus transmission is happening in the population. And so through that, you can also project the length of lockdown. The initial lockdown was 21 days, but clearly in our models, it showed that it was not enough. You need somewhere between 6 weeks in order to suppress the initial transmission of the virus. So I want to say that lockdowns are very ancient, and I don't think lockdowns are ever going to happen with this pandemic unless things become really dire, because we also did not know much about the virus. The lockdown was not just to stop the transmission of the virus, but to learn about the properties of the virus and scale up healthcare system. That was the main advantage of the lockdown to me, to just buy in time to know more and to build more. So we were very, very surprised, actually, me and my collaborator Devashri, who is the first author on that paper from Johns Hopkins. We are very surprised that this Medium article, single Medium article, probably received more attention than any of the many scientific papers that we have written in our careers. And it was picked up by the media. And we, as people, took attention and people took notice. And then came the very controversial and debated lockdown. On March 25th, it started, and then the initial announcement was for 21 days. And so you can see that there was a social process which you cannot really tease apart from the virus process in India and rest of the world. And the tragedy that unfolded with migrant workers, the galvanization process that was stimulated by lighting lights or diya all over India. And it was really, truly an unsettling time for the whole country. And so at that time, what were we doing as public health data scientists, how to contribute? We were building this app because we figured out very early onwards that it was not a matter of 21 days. It was not a matter of 6 weeks. These models are going to be useful and have to run for many, many days. And that's probably because of the history of infectious diseases, but also it just seemed like that a pandemic of this magnitude can run at least for a year. So we could not really put so much resources. So that's where data science came in, that we figured out a way to get the data from different websites and collate that into a pipeline and have an app which will not require human touch. So it will really update itself. Otherwise, it's not sustainable for a long period of time. So what happens is that every day the data gets downloaded in our app in an automated way. And then we run the models, we prepare summary statistics. And that's why I don't have to ask my graduate students or TAs before my talk to prepare these slides, because I just can go to the app and download what is the latest statistics for India. So you can see that we have been tracking obsessively this pandemic every day in a very granular way. So if you were there in May, you will see that the number of deaths and number of cases were at its highest, whereas you'll see that it came down in September. And now, yesterday, if you visited the app, you'll see that the test positivity rate is only about 1% in India. How many vaccine doses are being given? How many tests are being done? What is the number of cases? What is the number of deaths, and so on? So this has really helped us because we have picked up minute upticks, and we have this for all of the states as well. And that's another thing. The national data is still there, but subnational data, models for each state, which really helps to guide policy, were largely absent. So our app does fill in that useful gap with metrics. So if you look at the virus curve, the wave 2 in India, and I have placed the incidence curve in the United States as a comparison, that it was really, really sharp. And it was really like a virus inferno, which was probably a confluence of many factors. And so we'll talk a little bit about from first wave to second wave, what changed in terms of policy. I'm very cognizant that I'm speaking in the first school of public policy. I want to have that as a backdrop of my talk. So in terms of policy, the mood was very different as well. As it was mentioned that initially we were very scared, but gradually we let our guards down. We also had scientific misinformation in the sense that we felt that we have reached herd immunity because a lot of the cities were reporting a seroprevalence of 40 to 60%, and political rallies were going on, religious gatherings were happening, and you can see very little use of masks. As a scathing Lancet editorial said, that it was a self-inflicted national catastrophe. So now looking at, when we look back, we look at the entire trajectory of the pandemic in India, and that's why it has been sort of my project for 2 years. And again, if you know that if you don't have funding, if you don't have time, it's very hard to find this much time that we found to work on the project in India. But it was really through contribution of various people's time, and my university saying that, yes, if you're doing something for public good, then go ahead and carry on with that process. So you can see that this was the national lockdown, which seems so far in history right now in terms of the virus trajectory curve. And then wave 1 happened, and this is wave 2. And wave 2 was by all means much more acute than wave 1. In wave 1, India truly had flattened the curve, as you can see, build up healthcare capacity, testing, treatments, and did better in terms of the first wave. But in wave 2, there was also variance. We are going to talk about that. And so right now, where India stands as of December 18th, one measure that we use all the time is an effective reproduction number. You have heard in the literature, and that crossing unity sort of says the growth phase of the curve. And you can see that that happened in April and May of 2021, but it has been sort of hovering around 1 for the last 2-3 months. And so summary as of December 20 is 35 million total cases, about 477,000 deaths. Right now, case counts are very low. If you are sitting here in the real low value of the virus curve, it's very hard to anticipate the tidal wave that's going to come or crush you. So I just want to take a pause and moment that this is the nature that we feel complacent and we let our guards down. The virus is exercising and working out to come back at us. And this is the saga of human behavior versus the virus mutation that keeps a pandemic going. So, and the case fatality rate in India is about 1.4%. And and the reason I'm mentioning that, I'm going to come back to the death data and measures of fatality in India as one of the next topics of my talk. So this is vaccination data. And again, because I have this in the app, I can show you very recent data, recently about 7 million doses per day, an incredible feat, in fact, 1.37 billion doses. And the projection is that by February, there will be about 53% with 2 doses and 65% of the Indian population with at least 1 dose. But the question is that, is this enough? Because as in the United States, we are just talking about that, and the recent data reveal that for Omicron, what seems to be work is a 3-hit combination, which could be vaccine plus booster, vaccine plus natural infection. And we do not know yet some of the numbers which will help us to give a good prediction for India with Omicron. So again, I tracked this. I mentioned that I tracked this at a state level. I tracked this at a national level. So if you went to our app, there's a metrics table where we have, and you can see that many benchmarks, public health metrics, and number of cases, deaths for sure, but also fatality rates and the R value. And these numbers are not very reliable when case counts are very little, which we are having right now. Most of India's case counts have been coming from Kerala, and there is a lot of reason for that, that there is a widespread testing, detection of cases, but also the sero surveys showed that Kerala had only 40% people having antibodies by the time of the second wave. They were cautious, so there is more room for the virus to grow. So you can see that, so if you went zoomed into this, this is what you are going to see in terms of the different metrics. It has always been very challenging to maintain this app because of data gaps. So we often had to switch data sources, but I'm not going to get into the logistics of that. We also provide ranking of the different states which should be high alert in terms of different metrics. For example, here I'm plotting the R value. And again, right now the numbers are not that stable because the case counts are quite low, but we never stop tracking this pandemic for a day. Because there is no false sense of security here. You have to watch this process at a very granular level. There are many COVID curveballs that have been thrown at us. We do not want to make a mistake. So if you look at another very popular model, and Institute of Health Metrics and Evaluation from University of Washington, what their models are showing in terms of infections, what you see is that there is a bump if people do not adhere to public health interventions. There is a bump in late January and February, but nothing close to the second wave. And if you look at the lower part of the figure, which shows you the death projections, the top part is infection projection and the bottom part is the death projection. You'll see a huge gap between the red curve and the purple curve, which really leads to the theoretical excess death projection by the model, which is the top curve, the purple curve, and what is reported in India, which is the red curve. And you can see during the second wave, there's a huge gap in terms of what models are predicting, and this is not our model, and this has consistently been true, that the underreporting of deaths has been a feature of the data. So what about the Michigan model? The Michigan model never predicted a third wave. So we saw various articles in different parts of the last 3 months that the third wave is coming, it's about to start. I was really under a lot of stress to comment on the third model, but our models never saw the third wave in 2021. So it kept really low. And this was the model predictions that were happening in August. So I could never say that a third wave was coming based on the observed case counts. But now I think the dynamics, for the first time, I think since the second wave, I feel concerned. And so I feel concerned because there are so many unknowns about any of these models. So to build a model for the virus, what is going to happen in terms of forecasting, you need a model for virus transmission, you need a model for human behavior, you need a model for vaccine dissemination and vaccine effectiveness, you need a model for virus mutation. And then the last part, which I think is very important, that we do not have quantification of policy effects in India as well as data. If I ask that what percentage of reinfections have happened in India, what percentage of breakthrough infections are happening in India for Covaxin and Covishield, if I ask what percentage of people needed hospital admissions in India of the total COVID positive cases, none of these numbers, which should be there, accessible immediately, are available. So as a result, I feel this is a stochastic system in constant turmoil, always a few steps behind and always lacking the necessary data which will help us to pin things down. So, but still, we keep watching, right? So I want to show you the distribution of different variants in India over the last 1 year of 2021. And you can see that the different colors actually represent the different proportion of Delta, Kappa, all of these variants. And you can see the red block that Omicron is rising in India in terms of the proportion of genomes that are sequenced. Omicron is detected in a larger proportion, and it is going to probably take over Delta quite soon. So and then in terms of vaccine, the data shows that 2 doses do not offer enough protection, and even past infection do not offer enough protection. So the key question is that in India, how many people, very few people have boosters, probably none except clinical trials, but how many people actually had a past infection and 2 doses of booster to have a strong protection? I do not know that number. If India's vaccination database and the testing database and the clinical outcomes database will crosstalk with each other, we'll know these numbers every day, and we need to know these numbers. And so if you see like the projection for vaccine coverage, it's really a race between vaccines and variants. And I think that we are going to go through this issue of not being able to distribute vaccines equally, and then variants emerging. The cycles of boosting and vaccination and variants is going to continue until we work together as a world. So the second thing I think I sort of really is a nice segue to show these projections and say that the reporting in India has been really suboptimal. And so good models actually need good data. Nobody can produce everything from nothing. And data paucity and data opacity has been sort of a characteristics of the Indian data. And it is nearly impossible to capture all COVID deaths and infections for any country in the world, granted. COVID is a silent disease and asymptomatic transmission is a killing feature of this virus. So, but why are we then so concerned about the Indian data about deaths and cases? Capturing all COVID deaths is also very hard because there are some direct deaths and there are some indirect deaths. And sometimes the cause of death is attributed to a heart disease or a kidney failure, which probably was triggered by COVID, but you cannot really quantify and pinpoint that this was due to COVID. So there is our internal challenges with COVID infections and deaths. But then why are we so concerned? So let me introduce 3 simple measures of mortality or fatality here. One you have seen in the media all the time, which is the case fatality rate, which is the reported deaths versus reported cases. But it really tells us very little because according to every calculation, less than 10% of India's total number of infections were reported. And so in the beginning, the government and many agencies started reporting the second measure, which corrects for the denominator, that it corrects for the total estimated infections, which we got from national sero surveys, but really does not correct for the reported number of deaths. So I have never seen a stochastic fraction where the denominator is highly, highly uncertain and the numerator is known. So obviously, you know that you have to make correction to the numerator and the denominator both. And so you have to correct for the number of the estimated number of deaths, as you saw in the IHME model, that purple curve, that where is the correction for the numerator as well. So our team has worked a lot on this, estimating the total number of infections and the total number of deaths in India, and try to really summarize the work by others as well. So one thing which India has done exceptionally well is actually do serosurveys, right? So this is the prevalence of antibodies in the population, which gives an idea that what amount degree of infection was actually there, because many people are asymptomatic. So if you look at the seroprevalence studies from 2020 to 2021, you can see how these antibody levels have grown from 0.7% to 6% to 21%, and at the end of the second wave, 67%. So that tells us the estimated number of infections, if you multiply with the population on which the study was done, it's about 800 million reported infections. But the reported numbers are right now, as we saw, 35 million. And by the end of June, when these studies are comparable, it was about 30 million. So 1 out of 25 cases are detected in India. And that's due to various reasons. Mainly, the disease is mild for many people, and also people don't get tested. There is stigma, there is access to testing, and all kinds of issues. But so this is now what our model said. And when I first spoke about this, I was heavily criticized. But now there is seroprevalence data actually showing that 1 out of 25 or 1 out of 20 cases, and this is widely variable across states. Some states have better. So for example, just to give you an example of Kerala, for Kerala, whereas nationally it's 1 out of 25, for Kerala, it's 1 out of 6, because their testing protocols are better. So now if we go to this faulty measures of infection fatality rate, which has been projected that India has a very low infection fatality rate, so there is nothing to worry about, you get that if you correct for this estimated number of infections from the seroprevalence studies and say that, no, I don't believe the cases, so let me inflate the denominator, but I truly, truly believe the number of deaths, then you get 0.1% as the infection fatality rate, which is low compared to the global median of around 0.27%. But if you actually really try to do the calculation for total number of deaths, you need excess death data to be released, mortality data to be released every month nationally for every state in an honest way. So we only have anecdotal media reports from obituaries, crematoria, burial grounds during the second wave that a lot of deaths went undercounted and underreported. So for the United States, if we look at the excess mortality data, January 2021 calculation shows that US had 22% excess deaths, and 72% of those are attributed to COVID. So lack of data really makes it very difficult to do such calculations for India. We do have data on subnational data on some states, but we do not have credible national data. So many people have really delved into this problem and focused on certain states and quantified the excess deaths for India using various other existing surveys, family surveys, consumer pyramid surveys to come up with an estimate which are widely variable. So the estimates in the literature actually go from 2 to 5 million I'd like to remind you the reported number of deaths till date is 477,000, but any kind of estimate from any model, the range is 1.8 to 4.9 million. So it seems like there is an underreporting factor of 4 to 12. And of course, not all of these deaths can be directly attributed to COVID. There has been a large number of deaths, probably due to transportation lapse, people not being able to go to the hospital, delay in care, delay in screening, which has affected the low and middle income countries a lot more than the countries in the Western world. So if you look at the infection fatality rate corrected measure, where you actually correct for that estimated number of deaths, even if I take the lower bound of these estimates, even if I say, no, let us not get to 5 million, if I go to 5 million, just like 2 millions, the lower bound, you can see that the infection fatality rate in India varies from 0.4 to 0.5%. So this is huge, because from 0.1 to 0.4% is a lot of lives which are not replaceable, a lot of empty chairs for families, and those need to be registered and reported. So you can see that just by making corrections to the total number of infections from seroprevalence surveys and the total number of deaths from excess death data, you can make an impact. You can say that what is being projected is not correct. And that's why evidence synthesis becomes very, very important. So as I said that previously, when we did not have the data, we used mathematical models to come up with these numbers. And when we were first talking about this, and so in various papers, we produced these graphs that are very small fractions. So you can see the red, or the in the red and the blue, or red and the green, a very small fraction of deaths. Our estimates were 1 out of 5 deaths were being reported in India, and 1 out of 20 to 30 cases were being reported in India. This did not input any of the data that I showed you, but there is some method in the madness of mathematics that we are quite correct in terms of the ballpark. And so model-based estimates, which did not use the data that came later, which is right on the ballpark, gives an estimate of infection fatality rate of 0.4%. So I think that's why it's important to continue this work, because you can look at the data and the information from different prisms and lenses and say, regardless of anything, this is the lower bound, and what is being projected is just not correct. So this changes things. Why do we care? So this changes things in terms of resource allocation. And I think I'm a member of the World Health Organization Committee on Estimating Mortality all over the world. And we see that some countries have reported well. So for example, and this is the end of September data, because we have comparable data only to that point in terms of serosurveys. So if we think that the US has reported many more cases and many more deaths than India, so the total number of reported cases in US and the reported deaths in India is US is higher than India. But then look at the underreporting factors for infection deaths in US, and that gives you about an estimated infection somewhere 110 to 130 million, because the underreporting is 1 out of 3 cases in US were reported, and the underreporting for deaths is 1.6. So this will take you a total tally of the number of infections and deaths for US, which is actually smaller than the estimated number of infections and deaths in India. But as a result, you can see the fatality rates in US, US is a much older population, is actually higher than India. So these fair calculations are very, very important to know the truth, because you have to prioritize. Otherwise, you are underestimating the magnitude of the pandemic, and resource allocations at a global level could be determined by just the reported numbers as opposed to the estimated true numbers. So it really can change the ranking of different countries and also prioritization in terms of resources. So it's really important to get the accurate numbers. So we have heard throughout this pandemic, this struggle between lives and livelihoods, that what is the cost of these lives? So in this paper that we worked on, which recently came out in a special volume on COVID-19 in studies in microeconomics, we actually quantified, we did a value of statistical life type calculation to say that if you're thinking about lives versus livelihoods, when a pandemic is that acute as wave 2, those considerations become really tilted. And if you put a price to human life, then you can say that if you believe the true numbers, it's equivalent to 9% of India's annual national GDP. But if you don't believe those numbers, even if you take the lower bound, it's about 30% of India's national GDP. So the cost of human life, of course, this is trivialization of human life, but we need to really do such calculations as well from an economic perspective. So now I want to really touch upon the third part, which is really key to my heart right now, that we have rolled out all of these lockdowns, masking, social distancing, low occupancy in the educational sector, not having in-person classes. This has severe consequences to our learning outcomes, to our lives. So have we really taken the time to evaluate and tease apart what really works, and at what time, and at what frequency, and at what intensity? It's extremely difficult to do any kind of causal inference here because so many things are changing at the same time. But we should still try, because this is really key when we nuance our public health interventions for the next variant or the next wave. So what we saw, so this is just to show you that in Delhi and Mumbai, even in wave 2, when we instituted the lockdown, the R value came down very quickly. And also there was a sharp decline in the number of cases. So it seems like even for a country like India, lockdowns are the most stringent measures, they do work. But what else works, right? So how can you make these measures more humane and sustainable and economically and educationally more viable? So there is a ensemble of research now emerging to really quantify from all over the world, all of these facial coverings, closing down public transportation, restricting large gatherings and school closing. What is the effect? Which ones truly work? And so this is, I'm showing you for a paper in the Journal of American Statistical Association that I discussed, where this is for US, and we did most of the work in India, is that what really works, what has strong protective effect, if you look at the effect of the policy measured by decline in change in the RT value, or the growth of the transmission, you can see what really conclusively works is the stay-at-home orders, and these are different intensity of the policy level, and also facial coverings. So at every level, facial coverings work, undoubtedly. So when we are thinking about instituting and enforcing things, we prioritize, because every box here and every level within a box has really a lots of significant cost to the country. So we really have to get this data, what really works for India. And so in a recent paper, we tried to do this, that what happened during wave 2 and wave 1 in different parts of India. I'm just showing you what happened in Maharashtra. And we tried to deduce an estimate of that intervention effect, which I showed in the first part that we just came out of our head, that how much does it change, 20%, 10%? We didn't know it at that time. Now we have enough data to articulate what policies were instituted at different dates in Maharashtra in the pre-lockdown period, lockdown and unlock period, and map those policies back to how much did transmission change because of certain policies. And again, it's conjectural because I can never come up with a causal interpretation. And then we tweak those policies and just say, let us do the counterfactual experiment. If the government had really instituted these types of intervention nationally, what would the second wave look like? Was it not preventable? Was it just a destiny because of the Delta variant? Let us do that mathematical calculation, because we know and we have enough data now. And so what we do is actually come up with a counterfactual incidence curve and a counterfactual death curve by using observed data on mortality and intervention effects. And I really want to do more of this at a very thorough level. Even Maharashtra takes incredible amount of work, because you have to follow every day what was done. And so for every state, it is a challenging thing. But if a lot of us do it, it's going to be done. So what we did is that in the future, so this is really building from this framework to build a pandemic resilient future, that let us look at what happened. And let us see if there were triggers, for example, when the R first crossed 1, if we did what Maharashtra did much later on, if we just shifted those times, because this is a very dangerous thing where the subclinical manifestation of the disease and the transmission spreads for a while before you see it. So if we actually instituted different policies with different tiered intervention and strengthening of the public health measures, as we saw the R climbing up, crossing unity, going 1.2, going 1.4, and also some other metrics, if we actually had a framework, could we generate a different alternative reality? And the quantification says that if you acted in March, by March, April is too late. Even early April is too late. If you acted in the period of March when there are signs of growth, then a large portion, 80 to 90% of the infections and deaths could have been prevented. And so this is something, and this takes into account the multi-strain model, the Delta variant is rising, everything into account. So I think we need to do calculations like this. So when this paper first was released, there was a lot of political politicization is a hallmark of this pandemic. And as a statistician, I think when you criticize data systems, when you do such calculations, you obviously run into the risk of falling into the camps, right? Of course, it's very hard to maintain your unbiased allegiance to data and facts. So that has been a phenomenal struggle for me, who is used to work behind the scenes. And when I get these memes in, like, this is an example of one of the memes, that this is how the work is being interpreted and circulated, then it's definitely stressful. So you have to have the resilience and the strength in order to believe in your science and just speak science. So I do think that the data problem is there, but I think we should still try. We should still try to articulate the effect of intervention so that in the future, the mistakes are not being made. So I think that this time really changed me. And in wave 2, my entire family in Calcutta was really was hospitalized and struggling. And so it was very hard to see from afar the suffering of my own family, of my own country, and of my own community. And so I think that I sort of somewhere in the process, along with the data scientist, I became an activist and advocate and started writing articles in newspapers, which I had not done much previously, and speaking in television and so on, just to give some voice, because data can sometimes give voice to the people who are never represented in the data or could not speak. So I think that that's very important. So I think moving forward, in order to build this model, in order to really nuance your intervention and policies, you need data. And it's really very troubling to me that to this date, we do not have answers to very simple question about the reinfection rate in India from Delta variant. We do not have any idea about breakthrough infections nationally for the 2 different vaccines. We do not even have basic age and sex stratified mortality data. And I can tell you that this is a huge, huge gap. And India is not the only country which is lagging in data systems. US is also a prime example of not having good, connected, integrated national data. So all the good COVID papers from which we have learned about variants, we have learned about vaccine effectiveness in real time, have come out of Israel and UK and Denmark, because they have population-based cohorts. They have a national health system. They have an insurance system which has almost the entire national coverage. So we need integrated data systems which can crosstalk to be able to navigate solutions to this pandemic. So I seem like a broken record, but I cannot stop emphasizing the need for such data. So as I showed you in the figure for distribution of variants, Omicron is here. So I think that India needs to really scale up vaccine production, because it has to consider boosters at some point of time in the near future. regardless of what people are saying that, okay, 90% people have antibodies, given the data for Omicron, that there is not much protection from past infection and 2 doses of vaccine. I think it's really masks work against all variants. You saw that in the table. Every study that has been done, facial covering works. We really can do this, particularly when we are seeing this brewing. We really have to require masks in all large indoor gatherings and take the precaution. Have a careful eye on data in terms of sequencing, wastewater surveillance in rural areas, and scale up healthcare capacity, because there has been a lot of improvement and innovation in COVID treatments as well. I think data paucity, data opacity, and data denial not just hurts the public's confidence and trust, but also hurts the government itself in designing clever and judicious policies. So as we move forward, I think lots of infections may happen, and that's what we are seeing in the United Kingdom. We are seeing in the United States right now. And we hope with vaccination, most of the infections, even with Omicron, will be mild. So what we really need to track in terms of interventions is not the case curve, really the hospital and ICU needs, and what kind of suppression measures will help me to make the curve stay below that capacity that I have. So this is a very simple schematic that if we had this many 13.9 hospital beds and I allocated all of them to COVID patients, then I need to keep the curve at what level, and what level of mitigation and suppression measures is going to help us to afford those number of cases. That's the calculation we should do. And for that, again, we cannot have such simplified data. We need this data at a granular level to design policy at a very micro level. So I think that I tweeted yesterday about 10 steps to prepare for Omicron, and some of the things that I have mentioned. I will share a copy of the slides, but I think I have mentioned most of the points already. So in this talk, I have focused really on the prediction and forecasting of COVID. But there is much more to COVID beyond the forecasting or the statistical part. You really will probably study the effect of COVID and effect of policy on so many different aspects, including long COVID, including the toll it has taken on mental health, sheerly like loneliness and the struggle to find joy. And then on the country's nutrition and immunization policy, on economy, polity, and society, the list will go on. And as we think about policy, we have to look at the data as we design our main personal intervention strategies, because the public has a role to play in public health. So if you look at lots and lots of papers, what is the most risk conferring activity in our daily lives that we typically do is actually indoor dining in a congested restaurant. So this is very hard for me because I'm a big foodie, but I have really tried to maintain outside dining, and even with space heaters and live fires outside, I've never gone into an indoor restaurant in the last 2 years. So something that you need to decide for yourself, what are some calculated risks that we need to take, because we still need joy. With vaccination requirement and mask requirement, I have gone to see theater, which is a part of my life, but I have never gone to places where a lot of people take off their masks and speak loudly or eat. So this is something that we can do. So the pandemic and the policies are personal. And in 2020 November, I dressed up in this hazmat suit. I cannot believe it, looking like an astronaut to go to India, because I was really, really missing my parents. And so when I'm going in 2 years, I'm less afraid because I have taken all the personal prevention measures. So I strongly encourage everyone to think about balancing your risks and still find the source of sustenance and joy, because we need that. So we have learned a lot about being scientists during this time, but I just want to mention that we have learned that being human, how to be a human, and how to lead with science and humanity in the face of crisis is probably a benchmark of policymakers and leaders of this time. With that, I want to thank the school and also Subhashish for this kind invitation. I really think that I have been converted that you cannot really work behind the scenes. Data and statistics and statisticians are really important, and we cannot be silent. We cannot just publish our papers, we have to publicize it. So thank you very much for your attention.
Thank you very much. That was absolutely scintillating. You're such a gifted teacher. I mean, every sentence you spoke, every word was clear. Anyone listening to you would, there are some people, and this is one of those talks. I mean, I remember when I was in the Delhi School of Economics, Prashant Patnaik's classes, when he explained Arrow's impossibility theorem, I can still remember every word that he said, and it stays with me. You are in that mold, undoubtedly. You are a great teacher. People will remember very clearly what you said and why you said it for a very long time, and so you've done great service to not just to our audience, but if you circulate this PowerPoint, many more of our students who are not able to connect necessarily will benefit. The other thought that occurred to me when you emphasized why is it that India's, after all, we built our statistical system with Mahalanobis. We made a major contribution to the United Nations to build a worldwide statistical system. And now we are in a bad way. And I was thinking of a comment that was made by Mr. S.K. Day, who started the Community Development Program in India. And I invited him just before he passed away to a seminar where he made this statement that when we instituted the office of the Block Development Officer, little did I know then that this person would block development, right? Now, what it means is he envisaged a very highly competent person, one of the senior officers in the Indian Administrative Service, to be the BDO. Yeah. But in the system, they lowered that to a minor functionary. And in the process, they've lowered the status of statistics officers in districts to such a low level that they are rarely called upon. They don't even meet the district collector or the district commissioner. They are seen as, very low order people who don't know what is it that their purpose is in the system. No one tells them that their work is extremely important, that they must be diligent about how they gather these statistics, how they put these numbers together. So if you treat them so lowly and don't recognize their importance, and they don't know that they are very important for policymakers, and they have a very low self-esteem, they will cook up any numbers, right? They will not take the work seriously. So I think one of the lessons here is this, that we must, enhance the status and standing and give us meaning and purpose to people who collect data at all levels. And so one of the underlying points that I think I'll be an advocate for this cause, that we must increase the self-esteem and stature of the people who collect data and not treat them as, some low order people who are barely visible, which is unfortunately what's ruined the system. But when it was set up by people like S.K. Day and Mahalanobis, there was a completely different vision of what our statistical systems would be like. So, we've run out of time, but still, I think I ought to at least note any question there is in the chat.
I've been asked to assist you with some Q&A.
Will you help me?
Yes, I've been passed that responsibility. It's easy. I mean, I have some stuff.
Yeah, so I think I can read and respond to that question. I think it is.
There is a question for you there.
Yeah, so the question is that whether social distancing and mask wearing is difference lockdown makes versus only social distancing and mask wearing. So this is what we really studied in this paper, because we want to really act early with a strong enough measure. So that's the optimal fine tuning of interventions, because nobody wants to go to lockdown. But if you wait too long to strengthen your base prevention measures, like we are going to continue without masking till we see case counts rise, then it's hopeless. Then lockdown is your only choice left. That is exactly why timing is very key. So we show that if we started adhering to modest interventions, but from February and March, we don't need lockdown. We don't need such stringent measure. More than the strength, the importance is timing. This is something nuanced with that really people need to understand that if you really wait to see the curve, it's already too late. Then you have to go to the next level of measures. So that's the problem, right? You have to see something bad to convince people that you have to do this, but that's already too late. That's why you have to go to the lockdown. That has been so treacherous because human nature is that unless we see death or sickness, then unless we see that, we do not want to react or we don't want to wear masks. But to convince people that this is really a latent subclinical state and things are really brewing, and data shows that if we acted in February, we really could get away with much more modest measures. So it's really the timing, not even the length or the strength. If you act on time, you can really prevent a large number. So you have to intercept the curve before that exponential growth phase starts. So this is really incredibly important in terms of policy, because just think about 7 days of lockdown, the cost of to human life and earning and everything. So not to be able to quantify these, understand this, absorb this, and act. And leaders have to be able to be robust, compassionate, and yes, people will criticize you, but nobody can see that, the science behind it. And we now know that even in New York City, if they instituted in 2020 lockdown 2 weeks later, 2 weeks earlier, 50,000 lives could have been saved. So this is not rocket science. Now we know the timing matters, and you can get away with much softer measures if you act in a timely way.
Okay, I think you have to take the next one, because I think my colleague Pradeep Govind says something that was also at the back of my mind. I mean, we can have the best science possible, but I think India's problem is political. So we have a populist government in power, and so that gives Pradeep's question a lot of resonance. So you can read the question: what really are the options when the government and policymakers seem to turn their eyes away from predictions made in an objective manner?
So I think I would reflect on actually Dr. Sudarshan's point that India used to have this iconic people, right? Like Mahalanobis, that there were stalwarts involved in the governmental system who used to advise the government about statistical systems and forecasting and what is coming. There was sort of like a partnership with scientists that you cannot be an expert in everything, you cannot know everything, but if you listen to experts, then that could also inform policy. So I think there's a huge gap in terms of that policy and statistical intellect, that there is a partnership in the government and trust to act on that. And I don't know, shifting cultures is very hard, but I have seen in my life, that what can we do? I think scientists in India have raised their voices. If you think last 2 years, many people are writing about this data system. I just saw an article in the Hindu by Gagandeep and Gautam talking about the same thing. I am writing a whole piece on how to revolutionize India's data system because this is not the last public health crisis and we are not prepared. And if you set up 3 databases, which are very good in their own right, the CoWIN, the vaccination, the testing, and the sequencing, but they don't merge together. So we cannot get how many breakthrough infections are we having for Covaxin and Covishield in real time to understand the effectiveness, the relative effectiveness against a particular variant as the variant landscape is changing. Then we cannot do policy. We cannot really inform and talk to people. So I just this is just something of a consistent and persistent fight, and also people getting together and demanding actions and demanding transparent data. So I think that it has to be a movement. What can I say? It's just helpless, right? But I do think that we have to keep the work. We have to publish these papers in top-notch journals so that people believe these inferences and can quote them when they are talking to the government. I think this is something that I truly believe.
Okay. I had just a quick couple of questions. First of all, I recognize your father is a very important personality, theater personality, right? A movie personality in Bengal, right?
He's a theater actor for a long time. Yes.
Yeah, and then I realized that because of that, you and I actually have a family connection, which I will elaborate in a separate. My question right now is that you know, I really like that result where you show it's really mask wearing. You know, that can make a difference. I am doing some research myself on the effect of COVID on mental health, and one of the things I see, what makes people very upset also is, you know, restricted mobility. I think that has a lot of, you know, that creates a lot of anger. So this is a very, very important finding. I think you cited a paper by Quick, and then I looked that paper up. I guess so. You're saying that, you know, had they picked up had they gone in with, had they used the right tools at the right time, we could have prevented, you know, all this stuff. So that point is very well taken, and thank you for a fantastic presentation. My question is, because I'm working on that first wave, my question is, what about that first lockdown? I mean, in terms as a lockdown. As an epidemiologist, that was at a different point of time, right? So I'm talking here about March 2020, 24th March. That lockdown, giving, I think, 4 hours notice. Could there have been a better way?
Yeah, so I think that the lockdown was a right decision at the time, but the implementation was completely faulty, right? You can do, that's why I think you have to think about the intervention measures, their impact, and also how to really humanize them. So if you think about, I think Bangladesh, when they announced their lockdown, they gave 4 to 7 days for everybody to return to shelter. So it's basically not lockdown, it's shelter at home. So you have to pitch it in a humane way and also give people time to prepare, have transportation. So I think that in terms of just making the population static, because we did not know anything, we did not have testing, we did not have contact tracing, we did not have COVID care centers, we did not have isolation for just that purpose of scaling up capacity and save lives. I think that there was not much of a choice. Many countries did that because they did not know any better and we needed to know more. I do not think that's recommended right now. The recommendation is that we know masks wear. So wear your mask and go other places. So that's why I showed, like, maybe when you are hearing Omicron, we cannot really go into indoor restaurants, which are very crowded. We have to restrict the restaurants or go outside. India has good weather to go outside and set up, like in Michigan, even where it is a very snowy place. We have thousands of parking lots with space heaters being converted into eateries so that we can eat outside. So I think you have to bring the joy. Nobody likes this restriction, and it's a significant detriment to your mental health and well-being. And so, but what can we do? We know that what works and what are the most dangerous ones. Let us avoid those. So we can do this much, right? That we can say that, yes, I don't like being restricted, but I'm going to, when I'm with others, I'm going to wear my mask. And so if we think like we really need to have big weddings, regardless of what else is going on in the world, in a very crowded place with 1,000 people eating, I don't think we are doing the right thing here. And there should be public consciousness, but also government consciousness and strategizing that, okay, in Michigan, for example, students were asked to come back with a vaccination mandate and a mask mandate. Is it easy to wear mask for 8 hours? No. But the joy of interacting with colleagues, to be able to go to the whiteboard and derive an equation, makes me not complain about it, right? So I think we have to do a trade-off because we are in a bizarre time. So instead of shutting down the whole thing, if we do careful things early enough in advance, I think it's very, very important. And I would also like to, yeah, go ahead.
No, I'm just saying basically, so that lockdown, the first one you're saying, it was necessary, but it did not have to be that stringent, because it was called officially the most stringent lockdown in the world, right?
Yes, so I think that, like, we did not, as I said, that I'm forgiving of those times, because we really did not know. We did not have this data, that catalog that I showed you, what works. Now with 2 years of data, we really can be much more strategic and intentional and deliberate about what really works at what time, so that we can move on with life and not lose all the different privileges of being in a democratic and free society. So I think that we really need more data on this, that what really works. Then, and you saw like 5-7 different things. Going to a grocery store and where nobody's taking their mask off, nobody's talking and just shopping is the least risk conferring behavior. And we know that, like, we were not doing that, right? And I myself kept my groceries for 3 days in the garage before I picked them up, because I thought that transmission happens through spread. So these are redundant things. We now know that so we can focus on ventilation, we can focus on outdoor spaces, we can focus on masking. We would not need lockdowns. But if you don't do anything till you see that the case counts are so high, then you have no choice left to just, because so many people are going to get sick at the same time and the hospitals are going to crumble, right? So that's the main thing. If we can have a slow spread at a sustained level without everybody falling sick at the same time, then you can deal with this better. Because even if a small fraction of people fall sick, you can give them medical care, and the care has improved a lot.
Right.
Okay. So do you think now they're using a sledgehammer where they should be using a knife right now? I mean, like, if you go to India, if you're from at-risk countries, then you have to get tested 10 times, and then you have to get home quarantine. Do you think, again, this is like, again, overreacting when actually a finer tool could have been used?
So I think I had a sentence in my 10 steps that we definitely need testing for international travelers, but we need more testing for everybody who is having symptoms, and also random testing throughout the whole country, because I'm pretty sure that clusters are emerging and just going undetected. So just focusing on intensifying on international travelers is not going to help. For the longest time, and even now, I don't think India has officially declared that they have community transmission. This is the joke of the century, that you have 70% seroprevalence and you have not declared community transmission. So obviously it has happened. Even with Omicron, it has happened. So of course, intensifying testing for international travelers is a good thing. But I think that the issue is much broader, and you should really scale up testing. I want to answer one question which is in the chat quickly, that how do you know that it's an incorrect model or really death underreporting has happened? So of course, models are wrinkled with assumptions, so we never really can validate this model estimates. And that's why, I believe in looking at the problem from different prisms. I had a math teacher who always used to tell me, okay, this is the problem, do it 5 different ways. So I think that that's very important, because we do the mathematical modeling, but then the data came in from different states, the excess death data, which is corroborative of the mathematical modeling finding. And when I present the results, I actually present lower bounds. I said that okay, forget about the upper bound. Let us say that the lower bound is true for all excess death estimates. Even then, there is an underreporting factor of 4 or 5, right? So even the best case scenario is quite worse. So I think that you have to really do the due diligence in terms of sensitivity and robustness analysis, so you're not just fear mongering, you have some credence to your data.
Right. So I think we have to draw this fascinating session to a close. We have to bring you to our university. You come spend a lot of time with us. You'd be most welcome, and our students would be thrilled. As I said, you are an exceptional teacher, and anyone who's has the good fortune to listen to you is really fortunate. So
thank you very much. You are very kind.
Indebted to you for this talk. And we'd like to the list of restaurants, salons, the degree of risk in going to these places. I think I haven't seen that publicized. People would emphasize, wear the mask all the time kind of thing, but But this, I think this kind of a sheet should be circulated when we get our students back in February. We have to, we'll take that out and educate them that, they don't have to be miserable and, stay locked in their rooms, but they should spend a lot of time outdoors, but not go to, weddings and go to crowded restaurants and so on. So I think all of these are good public education measures, and all of us need to play a part in it to
Yes.
publicize this, to get it across to people. And so we've learned a lot from your talk, and we'll act on some of it. I don't, you're becoming an activist. That's very good. I mean, we have to bridge this division between activism and academics, and see that, this is, such valuable knowledge, and nothing is more noble than saving lives and appreciating the worth of life. So thank you for all the work you're doing, and welcome to our campus whenever possible. And we are very grateful for your talk. Thank you.
Thank you. You're very kind. Thanks, everyone.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Thanks, Subhashish.
It's a pleasure. I just realized I have a family connection with her.
How is Professor?
It's basically through my mother's side. It's a roundabout connection, but it's a
How are you related to her?
through my mother's side, basically, mother's sister's side. So it's convoluted. But seeing her father's
I'm
face,
so happy she showed that very happy photograph of her with her parents.
Father's face, I really, I know this guy. I know. That's how I made the connection.
Yeah.
But this was a great talk. And
Yes, this is an outstanding talk. I only wish more of us had heard it. I mean, more of our faculty. So you may not expect everyone to come to all the sessions of the conference, but at least when there is a distinguished lecture and we've singled them out, I would be happy if there was more esprit de corps and solidarity towards that. And as a school, we showed up in strength.
That's a long-term issue, actually. So I think, we've seen this in other situations as well. Especially, for some reason, talks around this time tend to be quite underattended.
Well, I mean, it wasn't that, the talk in the afternoon was also not.
That's true. Yeah, that's true.
I'm not talking about anybody else. I'm talking about us, our faculty. Yeah, that's all. I mean, there's so many absentees amongst our faculty in the talk in the afternoon or now. That's avoidable, right? I mean, Vivek is not there. Indraneel was there, I think, and then left. But this is on public health, at least that. And so then the PhD students.
I think Amunindra wants to say yes.
Yeah. So was there any confusion about the login side, because every that link was saying from 2 to 10, 2 to 10. So was there some kind of confusion also? Because
no, I don't think so, Amunindra. I think they sent out multiple emails.
Exactly.
Yes, multiple, and Lalit sent out reminders with the link. So
because this was really an excellent talk. So
yes,
absolutely. I mean, people who didn't attend it missed it. So
right. Okay. Well, thank you, and thank you, Avinendra. So this is good. I mean, we've started off a good series of conferences. I think we'll make this an annual event and go from strength to strength.
Yeah, and I think we'll have to figure out a way to get more students, I think. Involved. But I guess this is the first time, so I think it's quite positive.
Yeah.
So far.
Also, yes, that's true. Also, there is, I don't know. I mean, I don't think any of our faculty attended any of the sessions of the Indian Statistical Institute conference, which is also started today and runs into tomorrow.
I know. So that could have also been. I mean, that could have drawn some audience as well.
Yeah.
But we just had
Anyway, we are learning. We should publicize this a bit more. and have not just us but others benefiting from this. It occurred to me that this particular session we should have circulated it to all of the institutions that have a public policy program, that are members of this association for public policy education that we've just set up. We've just registered it, and I'm circulating. I think I circulated the MOU of that association, but we've got members, founding members from other institutions, and so their faculty would be interested in listening to someone like this talk, particularly because it has such public policy significance.
Well, all I can say is we have great speakers, and I was attending some panels, great papers.
Yeah, sure.
So maybe
Absolutely.
next time more advertising and so on. We can take care of that next time. But I
Very
think
good. Okay, I'm feeling very
good.
upbeat.
I mean, yeah, I'm thoroughly impressed.
Yeah.
Okay. Okay. Bye bye. Bye bye.
Right, what did you say, Avinindra? You said something?
No.
Okay.
Okay, bye.
All right.
Move to the another. Yeah, please move
Next.
to the
Okay,
another.
thank you. Yeah,
Yeah,
bye.
okay. Bye.